Thank you.
I will invite Dr. Saswati Sinha. She's a senior consultant critical care from Manipal Hospital. She's going to talk on, I think, very interesting topic, the classification of cardiogenic shock.
So good morning again. We come back to the thematic of shock, and we're going to talk about the Society of Cardiovascular Angiography and Intervention, how they have classified cardiogenic shock and why. So we know that over the last 50 years, with the advancement of reperfusion strategies, the treatment for acute MI and heart failure has progressed significantly, improving outcomes. But we all know that cardiogenic shock may occur prior to or even after reperfusion. And despite whatever has changed in the reperfusion strategies, if a patient lands up in cardiogenic shock, the mortality rate is still a staggering 40 to 50%. And when the shock trial was published, uh, which basically tried to address that when the patient lands up in cardiogenic shock, should we attempt to reperfuse all the occluded arteries or not? At that point in time, the only mechanical circulatory device which was available was IABP. But over a period of years, now we know that we have other mechanical circulatory devices which are being used more and more in advanced setups. And we also need to keep in mind that cardiogenic shock usually takes care of a heterogeneous population in terms of etiology, the severity of shock, and also the comorbidities which eventually dictate the outcomes. So a better classification of cardiogenic shock was required, which probably prompted this society to come up with the classification. So basically, and this was important because cardiogenic shock is handled not only by the cardiologists, but also the cardiothoracic surgeons, the doctors in the emergency room, in the critical care unit. So a lot of these societies came together and they tried to propose a new definition which was simple and intuitive, which could be rapidly applied at the bedside, which could be used to reassess the patient as they progressed along the clinical course, multidisciplinary applicability, like I mentioned, and also had a prognostic potential. And so they came up with this schema of A, B, C, D, E, where A is a patient who is at risk. So the patient is otherwise okay, not in shock yet, but probably has an acute MI or probably has an underlying heart failure, and so this patient is at risk of developing cardiogenic shock. Moving on to B is the beginning of cardiogenic shock. So the patient starts developing hemodynamic instability, either in terms of a compensatory tachycardia or a hypotension, which may not be hypotension overtly, but at least a significant drop in systolic blood pressure or a MAP from his or her baseline. Moving on to C is the classic cardiogenic shock, where you start seeing signs of hypoperfusion like we see in shock. So the patient might have cold mottled extremities, a decrease in urine output, an altered sensorium. Moving on, if a patient is in classic cardiogenic shock and the initial set of interventions has been given to resuscitate him or her, and the patient is not responding or deteriorating with the current treatment, it moves on to stage D. And when we talk about stage E, this is the patient in extremis who has probably come in cardiac arrest, is being resuscitated on multiple vasopressors, on mechanical circulatory devices, but we are not getting a proper outcome. So there has to be a difference between stage C and stage D, and you need to have a defined time to say that no, this patient is not responding to the initial set of interventions, and the time limit was set as at least 30 minutes. And depending upon the stage of cardiogenic shock, A, B, C, D, E, the patient's clinical parameters, like a patient had completely normal clinical parameters, normal mentation, warm peripheries, hemodynamically stable. When you go to stage B, the hemodynamics start getting altered. Stage C starts showing an elevated lactate, organ perfusion is hampered. Stage D is anything but stage C and not responding. And then you move on to E. There was another important point which was addressed is a cardiac arrest modifier. So whichever stage of cardiogenic shock the patient is in, one episode of cardiac arrest can be a significant modifier of the trajectory of the patient, irrespective of the duration. So it may be a patient in the B category where the shock is just beginning. The patient is just hemodynamically becoming a bit unstable. But in the setting of acute MI develops a ventricular fibrillation, stabilizes promptly with one shock. The outcome in this patient is likely to be completely different from a patient in extremis with a prolonged arrest, severe instability. This is the patient who is likely to develop a multi-organ dysfunction. So an arrest again is a major modifier of the trajectory. There are two key components if a patient has a cardiac arrest. What is the time to the return of spontaneous circulation? And how soon does the patient have a neurologic recovery? Because that will also go a long way in prognosticating how this patient is going to go ahead. So the physical examination, like we already said, uh, depending upon the clinical examination, we know which stage this patient is in. Biochemical parameters might help to a certain extent, but that is usually when the patient reaches a stage of hypoperfusion. There could be certain parameters and certain biomarkers which can, like CK, CKMB, troponin, lactate, blood gases, BNP, can help us assess the progress of the patient and prognosticate the patient. As far as hemodynamics are concerned, conventionally when we talk about cardiogenic shock, we are talking about a low cardiac index and elevated filling pressures, echocardiography, blood pressure monitoring, and often when these patients progress on to advanced stages of shock, placing a PA catheter and investigating the or looking at the hemodynamics a bit more closely probably gives us a better idea as to which way to proceed in terms of fluids, vasoactive agents, and so on and so forth. And this is a study which was performed by the uh, cardiogenic shock working group, and they classified the group of patients depending upon these shock stages. And they also assessed that whether PA catheter and hemodynamics measured therefrom made a difference. And they found that only in 40% of the patients, they had a complete hemodynamic profile monitoring by the PA catheter. And the subgroup which had the complete hemodynamic monitoring by a PA catheter had a better outcome as opposed to others which had a partial or no monitoring at all. It's also important to keep in mind that oftentimes, even if we think that the patient has come in with cardiogenic shock, 20% of the cases there might be a mixed etiology. So if the patient is not responding to your initial interventions, this is time to look into the hemodynamics even more closely. This same classification was validated in multiple studies in the cardiac intensive care unit, and it was seen that as the stage of the shock increased, the mortality rate steadily increased, which validates that this can be applied in the patients in the cardiac intensive care unit, whether the patient had acute coronary syndrome, whether the patient had heart failure. This classification seemed to work better in terms of prognostication. And as the shock stage increases, there was a significant mortality risk stratification which was possible if this particular stage was assigned to the patients. Similar validation studies occurred across acute heart failure cases, which gave a real world validation of this particular scheme to identify patients with a risk of in-hospital and long-term mortality. And this was also validated in out of hospital cardiac arrest, where again prognostication becomes exceedingly important, and higher grades of shock were associated with higher mortality, increased needs for RRT, and mortality due to multi-organ dysfunction. But after all these validation studies happened, the same group of experts got together and they found certain issues which came up through the validation studies, and they found several areas of potential refinement. So they wanted to re-evaluate the original shock stage classification, as they found that if a patient is in stage A and has an acute MI, the likelihood or the prognosis is going to be different as opposed to a patient who has a chronic heart failure. So stage A might have two different kind of patients. In stage B, there might be hemodynamic instability. You may not be able to predict until and unless you have advanced hemodynamic monitoring. And similarly, it was important to refine the further stages, and therefore they wanted to modify things a bit further. Because in a lot of these studies, they found that it was a retrospective evaluation of the database. So it was easy to apply the parameters and prognosticate. But if you look at retrospective data, it was not always possible to get all the parameters properly. It was again a little bit difficult to differentiate pre-shock, that is stage B versus stage C, because biomarkers again become important in an acute situation, but in a patient with a chronic heart failure with a low cardiac index, the lactate may not go up that abruptly. Other causes of increased lactate might be confounding variables, or a patient may have a normal lactate with other features of hypoperfusion. So that is the reason, again, redefining things further came as priority. Classifying again stage C to stage D, that is deteriorating. How long do you wait to say that the patient has progressed from stage C to D? 30 minutes is okay, but again, the uniformity of escalation strategies will differ from unit to unit, from physician to physician. At what stage would you like to choose the second vasopressor? At what stage of the second vasopressor would you like to choose a mechanical circulatory device? So there are a lot of gray areas as far as those were concerned. They modified the issue of cardiac arrest. They thought that cardiac arrest was significant only when it ended up creating a neurological problem or a risk of anoxic injury. So a patient had a brief cardiac arrest, but then wakes up and the GCS is more than 9, then this cardiac arrest is unlikely to impair the long-term outcome. So this was a modification, it was done. They considered that whether age should be included as a modifier, but because older age always is thought to be a deterrent to using more advanced therapy, but ultimately they found that age is probably just a marker of more comorbidities, frailty, and there was no definite threshold beyond which you should deprive a patient of certain therapeutic interventions. I'm sorry, this is the view is not correct. So they really put certain values of the lactate as the stage progressed further. And they proposed a three-axis model. So it is not only the severity of shock which makes a difference, but the phenotype, the etiology, and the hemodynamic profile. If you look into it further, all of those things make a difference when you try to prognosticate a patient with cardiogenic shock. So they updated the shock pyramid, and now you can see gradations within the same stage. There are gradients of color, and so it's important to individualize patient care irrespective of what stage they are in, on the background of what risk modifiers they have, what comorbidities they have, and at what phenotype of cardiogenic shock they have presented in. It's also important to understand that it is a dynamic process, and like the patient might deteriorate and land up in a cardiac arrest, but there are certain recovery pathways, say following reperfusion, following pharmacologic or mechanical circulatory devices. If the shock reverses, then the patient goes upwards in the recovery pathway and can get cured completely. So to summarize, the shock stage is an indication of shock severity. It needs to be placed in the context with the etiology, phenotype, and risk modifiers ultimately. Since the progression across the shock states is a dynamic process, it is a it helps in making a common terminology when you are communicating with your consultants from other specialties, or it can help you take therapeutic decisions or also in designing trials. Cardiac arrest modifier is redefined to when there is a concern for anoxic brain injury. Say if a person has a cardiac arrest and the GCS remains less than 9, then that's a poor prognostic indicator. Lactate levels and thresholds have been highlighted in the revised modification, and it can serve as a hub and spoke model. So if a patient is progressing in terms of shock, this is probably the right time to consider transfer of the high risk patients to centers which have ability to provide mechanical circulatory support. So thank you very much for your attention again.
Thank you, Dr. Saswati, for that extensive throwing highlight on the new classification and how it will be more useful from the older one. I think with paucity of time, we just have one question. If there is any question, we'll take only one question. So if we do not have any questions, back to the organizers.
Thank you, chairpersons. On behalf of the ICCM Hyderabad, we would like to felicitate the chairpersons. So I request Gopinath sir to please felicitate Dr. Mahesh Marda sir with a small memento. I request Saroj Pushti sir to please come on stage and hand over the memento to Dr. Udaylal sir. Now I request Dr. Saroj Pushti sir to uh, hand over a memento to Dr. Faraz Farishta sir. Thank you so much, chairpersons. Now we move on.